Okay, perfect. All right. So good morning, good afternoon, good evening to each and every single one of you. I'm Dr. Akwi Asombang, interventional gastroenterologist at Massachusetts General Hospital and director of the Global Gastroenterology Program at MGH. Super excited once again to have Mukhtar Dr. Ahmad present with us today. He's a friend. We've worked together for many years. We've traveled together. So this is extra special to me. This is sort of like let's hang out and talk about the anus of the rectum. So I'd like to welcome each and every one of you to the conversation today. In terms of the format, first of all, this is a CME eligible program. We'll share a slide, get the information so you can get your CME. It's a free CME program. He will present, and at the conclusion of his presentation, I'll go through the questions and we'll engage in conversation. So feel free to send your questions through the chat or the Q&A. This program is being live streamed onto Facebook. I may not see the questions on Facebook, but we're also recording this and we'll upload this onto YouTube. And this will be submitted for internal viewing for those within the MGH system. So once again, it's a CME eligible program. He'll incorporate the CME information in one of his slides. So when we get started, I will go ahead and I will introduce Dr. Mukhtar, and then I'll hand things over to him for the presentation. So he is a minimally invasive, so a keyhole general and colorectal surgeon based in Dorset on the south coast of the United Kingdom. He is a certified robotic and laparoscopic colorectal and general surgeon with special interest in colorectal cancer and treatment of pelvic floor disorders such as prolapse, incontinence, and constipation. His interests in general surgery include laparoscopic hernia surgery, complex abdominal wall hernia, and hemorrhoids. He has published papers in peer-reviewed journals and presented at several meetings in his areas of interest. He holds a Master of Medical Science degree with distinction in cancer studies from the University of Sheffield in UK. His MBBS, that's his primary medical qualification from Nigeria's premier university, the University of Ibadan, and a postgraduate certificate in medical education for surgeons from the University of Dundee. He has a fellowship in general surgery of the Royal College of Surgeons of England. He also gained considerable management and leadership skills in his roles as the clinical director for surgery at Poole University, the lead clinician for colorectal cancer since 2016, and specialty lead for colorectal surgery. In his role as a clinical director, he gained considerable experience in medical leadership and played a significant role in supporting his specialty through a huge transformative program with the merger of the Poole and Royal, you'll have to help me with the pronunciation, is it Bournemouth? Bournemouth? How do you say it, Mukhtar?
Bournemouth.
Bournemouth Hospital to form the new University Hospitals, Dorset. He's passionate about patient safety and quality improvement and has brought his experience of implementing patient safety programs in Africa to his NHS work. He is currently a trustee of 3 charities working to provide free basic health care, clean drinking water, and quality education to the underprivileged children in the Sahel region of West Africa. Just a few quick highlights about his interests and hobbies I enjoyed. In his spare time, he actually enjoys gardening, reading, history and politics, and the great outdoors with his family. He's also a keen tennis player, cyclist, and enjoys running. And he's discovered the joys of skiing and now doing red runs. He spends a third of his holidays doing charitable work within the African continent. And on that note, I am very grateful to Dr. Mukhtar for taking the time and his dedication to medical education and training. As mentioned, I've seen him in action. We've worked together. He is a phenomenal speaker. So as you sit there, there's so much you'll gain. And please do not hesitate to ask questions if you're embarrassed. Because yes, talking about the anus and rectum can be sensitive for some. Feel free to send me a private message. We talk about these things every day. So send me a message and I'll be happy to ask the questions on your behalf. And on that note, Mukhtar, over to you. Thank you, thank you, thank you. I appreciate it as always.
Thank you very much, Akwi. It's the honor is mine. It's really great to see you here. I think the last time we were together, we were in Zambia, one of the best times I've ever had, one of my best trips. So yeah, hope we do more in time. Can Are my slides visible? Are we
Yeah,
seeing
but they're sort of
the
like in
typing
that
slide?
funky mode where we can see
Oh,
like all the slides. They're not necessarily in like presenter
oh,
mode.
okay.
Yeah,
So
almost there.
uh,
Yep.
it was meant to be uh, in a presenter view. How's that?
No, it's still the same. It was
So
close.
let's try. Let's try. How's that?
Oh, perfection.
Okay, good.
We did it.
Okay, thank you.
All right.
So I describe myself as a bum doctor to most people because even though I'm a colorectal surgeon, I do big robotic surgery. The trickiest part of my trade as a colorectal surgeon is dealing with anorectal conditions because when you get it wrong, the impact on the patient's life could be quite drastic. So Akwi's introduced me. I won't go into that again. So this is the CME slide, which I've also added to the end of the presentation for anyone who needs the details for that. So in terms of objectives for today, we'll define what we mean by hemorrhoids, fissures and skin tags. We'll discuss classification, talk a bit about what predisposes people to it, and how we make a diagnosis. How do we evaluate these conditions? And interspersed within the talk will be when to refer, which the answer to that always is when you're not sure, or when you think somebody else who deals with it more regularly than you needs to have a look at it. And I have nothing to declare, and you can see Akwi's declaration there as well. We've gone through objectives, but important to recognize common anorectal disorders. What are the differentials? Apply some evidence-based management and understand common pitfalls, particularly as it pertains to the treatment of hemorrhoids, which has an outsized morbidity in terms of things going wrong in its treatment. So considering how small it is and the fact that nature has decided to hide it down below where nobody can see it, the anus has an outsized, role or representation on the brain. It has, when it has this grip on people when something goes wrong with it, right? If you've ever had a painful anorectal condition, or if you've had an itchy bottom or a leaky bottom, you would have experienced pain that is very disconcerting. And even if it's discomfort, it does not let you concentrate. So, fun fact, the anus has a brain. It is smarter than any machine that has ever been invented by man because it has pressure sensors that can tell you whether you're about to lose control of wind, liquid, or solid. Have you ever thought of that? And after the nipple has the highest number of nerve endings, which, I'm personally grateful for because I quite like it to tell me what it's getting up to. So globally, like anywhere else in the world, there's no difference in distribution in terms of common anorectal disorders. There's a higher incidence of presentation to healthcare professionals in the Western world, but that's largely because of availability, particularly in low and middle income countries. Colorectal and anal cancer is often misdiagnosed as hemorrhoids. And, when we were in Zambia recently, we and I and Shagun and our other friends, we saw two young people, both of them in their 20s actually, that were initially diagnosed with hemorrhoids. And by the time they presented, because the hemorrhoids didn't get better, one of them already had metastatic disease, which is quite sad to see. And there's a substantial quality of life burden. If you imagine if you're having to clean yourself a lot and you never clean, or you're leaking or bleeding a lot, and as we mentioned earlier, disproportionate risk of complications. You could do a major abdominal operation and resect a lot of bowel and have very little in terms of significant effects. But if the wrong person does a hemorrhoid operation, divides the anal sphincters, then that's potentially incontinence for life. So in terms of anatomy, the anal sphincter, the hemorrhoids are not abnormal, right? We are born with them. We're born with something called anal cushions. So up here, when we're born as babies, and up here, you will see that we're born with, on the clock face, at 4, 7, and 11 o'clock, we're born with anal cushions, which are like the valves, like the tricuspid valve of the heart. It keeps the anus closed. Your anal muscles can only close your anus 85%. The rest of it is done by the anal cushions, or when they get bigger, we relabel them, we rename them hemorrhoids, but they are not abnormal unless they get too big. And which is why, as we'll come to talk, you'll see that cutting them out is not always the best option. The dentate line, the importance of this is that hemorrhoids are generally not painful unless you have this sort of hemorrhoid that has thrombosed, an external hemorrhoid that has formed a clot in it, usually because you've gone to the loo and pushed too hard. So painful hemorrhoids is generally like a red rag to most colorectal surgeons. If you have a painful bottom, generally you don't know it is not hemorrhoids, it's something else, and we'll talk about what those might be. The dentate line is the demarcation between visceral and somatic sensation. So just about in the upper third of the anal canal, there's a transition, which is where the brain of the anus is that I was talking about. This is where the pressure sensors are that tell you what you're about to lose control of. And it tells your brain which one it is. And if you happen to be at a dinner party, you can then send signals down to say not now, or your brain might tell you actually you can't wait, you need to go. So all that, you know, in real time is happening. But, think about all of the things that are happening at a molecular level, at a microscopic level, to allow you to control your bottom. So the internal external sphincters. So the internal sphincters are under your body's control and you can't regulate what they do. That's why you don't leak at night, because when you're asleep, your brain recognizes that you're not awake and it keeps it shut. When you're awake and your rectum fills up, it sends signals which, through a reflex, the internal sphincter starts to relax. If it's not a good time for you, you can squeeze your external sphincter, which is under your control. So continence is a measure, it's a combination of factors. First, of the consistency of your stool. So if we all had diarrhea, we would all leak because the rectum was designed to hold sausages, not designed to hold liquid. The second is the innervation. So the nerves need to be intact that supply the hemorrhoids. The third is the muscles of the rectum need to be normal, so not diseased by proctitis, for example. And then the last one is the sphincters themselves, that they need to be intact. So how do we evaluate someone with anorectal conditions? First of all, a good history, as Akwi mentioned earlier in the lovely video that I saw earlier on Facebook, about take a good history, ask when it started, how long ago, what are the other factors associated with it? Is there incontinence or leakage or soiling? Is there pain, which would open you up to other differentials if they're painful? What else happened? If it's a female, you want to know about parity, you want to know how they had their children, you want to know about history of previous surgery because there could have been damage, and it would help you to work out which procedures to consider and which ones to avoid in someone who's had previous surgery. So then you come onto inspection, and this is your best tool. The educated finger of a gastroenterologist or a surgeon is better than any of the other clever gadgets that we have, right? Feeling inside, feeling for any abnormalities, any masses, anything that feels like it's out of that feels abnormal, that might trigger you to do something else. But the inspection's also key. Looking around the anus, looking for discharge, looking for swelling, looking for any excoriation of the perianal skin, looking for openings potentially of an anal fistula. And you also want to see the inside of the rectum. So for any anorectal conditions, if there is not any of the other red flag conditions, which we'll talk about as well in a bit more detail on the next slide, you would you would still want to see the lining of the rectum. You don't necessarily need to do a colonoscopy, but you could consider doing a proctoscopy, rigid or flexible, just to check that there is no disease inside the rectum, like cancer or colitis, proctitis rather, that would explain what you're looking at on the anal verge. And some of the red flags as pertains to hemorrhoids and the history is the description when a patient describes tenesmus, which is a painful, um, pointless urge to open your bowels when there's actually nothing to pass. And that often indicates disease inside the rectum or a change in the in your bowel pattern. So red flags, again, these are things to think about, make you think about as this patient got colorectal cancer, persistent change in bowel habit, usually up to 6 weeks, weight loss, significant weight loss, up to 10% of the body weight, iron deficiency anemia, abdominal or rectal mass. So patients come with hemorrhoids, examine their abdomen as well. It is not an isolated organ, it is the exit of, a long tube that starts in your mouth and ends in your bottom. So always think about it like that. Don't think about it in isolation. Persistent bleeding, and then the family history. If somebody has significant family history of colorectal cancer. So I took this picture of um, another presentation, um, just to sort of to discuss the differences between what is a fissure, what's a fistula, what are hemorrhoids, because we often use, particularly in primary care, our colleagues in primary care, family medicine often use these terms interchangeably, and patients often use them interchangeably as well. So a fissure, as the word itself, describes, is a cut, is a tear in the anal canal, usually caused by pushing against a closed door. So inappropriate or uncoordinated defecation. Usually men, fissures are much commoner in men because men are obsessed with going to the toilet at a particular time of day. First thing in the morning, a lot of men say, my bowels are like clockwork. And I say to them, nobody's bowels are like clockwork. Their bowels change every day depending on what you've eaten. So going to the toilet to force yourself every morning is how hemorrhoids and fissures largely form. And once the fissure forms, the anal sphincter goes into spasm and then you get pain. So every time you open your bowels, you repeat the injury and then it becomes persistent and becomes a chronic fissure. What's a fistula? We'll talk about all of these in a bit more detail. A fistula is an abnormal tunnel connection between the inside of the anus and the skin outside the anus. And it starts by cryptogenic sepsis, so an abscess inside the anus that opts to dig a tunnel to drain itself through the outside rather than take the easier route. Why make it easy for you? Take the easier route to drain into the anal canal. What are hemorrhoids? So hemorrhoids, in lay terms, we explain to patients that they're swollen veins, but they're not veins. They're actually this tension of the anal cushions that we talked about in the introduction. And again, usually caused by excessive straining. In women, it could be triggered by childbirth, for example, or pregnancy, or other changes to the pelvic floor that might come with the menopause and aging. So the standard classification of hemorrhoids is the Gallagher classification. There are different names given to this classification in different parts of the world, so you might know it by a different name, but the classification is the same everywhere I've been in the world so far. Stage one are not really hemorrhoids. Stage one are the anal cushions. This is what nature gave to us when we were born, right? So they're here, they just stay inside and do their job of keeping the anus shut. Stage two are hemorrhoids that protrude when you strain. So when you're examining a patient, ask them to push, and you will see the hemorrhoids bulging. You often see referral letters of people saying they could feel hemorrhoids. I don't feel them. I don't know how other people feel them because they're soft and squidgy. So you can see them. The way to find hemorrhoids is to look at them, not to feel them. So you can't feel them unless they're thrombosed and they become hard. So when they protrude, that's stage two. Stage three is protruding hemorrhoids that have to be pushed back manually. So you either find them outside already, but can be pushed back and could stay in, whereas stage four are hemorrhoids that are outside and would not return. Um, so that means they have a permanent external component, which is which is irreducible. This is, I think, for me, probably the most important slide in this presentation, because one of the things that Akwi asked me to talk about is when to refer to a surgeon. And I don't have a slide about when to refer to a surgeon, but I'll talk about it through the presentation, and I'll be happy to be stopped and to take questions about it as we go through. Um, the key thing to say to a surgeon is what stage you think it is, because if you try to streamline the patient's pathway, particularly in the National Health Service, where people are waiting a year sometimes from referral to come to clinic, if I trust the description of a colleague in another specialty to say to me, these are stage four hemorrhoids, then I'm not going to try to band them. I'm not going to try to inject them because they're not going to go away. They have to be cut out because that's the only thing that will fix them if the patient is fit. So it helps us determine what the next step is. Whereas if you tell me they're stage two, then I might just book them into a clinic where I could band them so I could streamline them. So the important thing is the description. And if you can't remember the staging, just describe it. Just describe what you saw, because that would help us to direct the referral to the appropriate clinicians. So conservative with a small c therapy, this is what patients should have been told in primary care. And I know that there are primary care physicians on the call. So increased dietary fiber, adequate fluid intake, avoiding excessive straining, toilet behavior retraining, simple things like asking people not to take their phones into the toilet. It's not an extension of your living room. Do not take books into the loo. Observe the 5-minute rule. If it doesn't want to happen, get up and leave. Let nature tell you when it's ready, and then you can come back again. Put your feet up on a stool. It helps to relax the pelvic floor and to improve your coordination. So the next step, these are for grade two or three hemorrhoids, office procedures. These are things that can be done without a general anesthetic. So rubber band ligation is where you use a device. There are lots of different brands and different ways of doing it. The commonest form is a ligator that has a suction uh, device attached to it. The suction sucks the hemorrhoid into the tip of the device, and there's a sort of a plunger that allows you to push one of these bands onto the hemorrhoid. So it's not the hemorrhoid itself that you band because that will be incredibly painful. But all the diagrams that I can find, and I'm not good at making mine, so show you that the hemorrhoid is being banded. If you band the hemorrhoid itself, because it's on the dentate line, the patient could either kick you or punch you or scream very loudly, right? Because it'll be very painful. So you band the mucosa above the hemorrhoid because that's where the blood supply to the hemorrhoid is. What you're trying to band is not the hemorrhoid. You're trying to tie off the blood supply, the hemorrhoidal artery that's supplying the hemorrhoid, and that would band then falls off, usually 5 to 7 days, and by then it's done its job. Uh, Infrared coagulation is another possibility. Laser treatment, I didn't put a diagram of it because it is still under research and being done an audit measures in the UK. I would be keen to hear what the experience is in the States. So it's not standard offer in the UK. It's offered in our centre by two of my colleagues, but still being done under trial conditions. Sclerotherapy is generally no longer performed in the UK but it's still performed in many other parts of the world, including Nigeria, where I often go to teach and to work with colleagues, um, and that involves injecting phenol oil, which is a sclerosant, and there are other sclerosing agents. One of the reasons why it became unpopular in the UK was because there were quite a few cases of prostatitis because when you inject anteriorly, it is very difficult to gauge. The prostate is just in front of the rectum, and injecting into the prostate could cause very painful chronic prostatitis. But in the hands of experienced clinicians and with the right concentration, it should not be a problem. So surgery, uh, there are many different operations, as you'd imagine. I focused on the three commonest performed operations, which if we start from the bottom, so the top is the most invasive. Excisional hemorrhoidectomy, described in the UK as the Milligan-Morgan hemorrhoidectomy, but described by lots of different eponyms in different parts of the world, where you actually cut out the hemorrhoidal pedicle, preserving the anal sphincters, and that this has an almost 100% success rate. If you do this, it's extremely unlikely it'll come back. But we'll come to talk about that's not always why that shouldn't be the first line treatment. Stapled hemorrhoidopexy has gone out of fashion significantly in the UK. When I was training, 14, 15 years ago, um, I was doing lists, with my bosses of 10 of these on a morning list, but I haven't done a single one as a consultant because uh, after many, many years, we started to notice an increase in stenosis and urgency after this procedure. It's very effective, but what it does is to cut out the mucosa above the hemorrhoids and pull them up. So it fixes the prolapse, takes away the blood supply. But you formed an anastomosis in the lower rectum, and that could cause problems. Not in all patients, but it could. So for me, my favorite procedure is the hemorrhoidal artery ligation and rectoanal repair, where you use a probe that has an ultrasound, a Doppler in it that helps you to identify the hemorrhoidal artery. You put a stitch through it, and then you do a running concertina stitch to pull up the prolapse inside. Very effective, about 80 to 90% in experienced hands. But the trial compared the Hubble trial, and it did not find a difference between hemorrhoidal artery ligation and rubber band ligation in experienced hands. Um, but I suspect, again, like with every trial, there's lots of differences in the patients. There's lots of differences in the skill set of the people involved. So, what could possibly go wrong after a hemorrhoidectomy? You're looking at early complications. So, you're looking at things like pain, bleeding, which could be primary, less than 24 hours, or secondary. This is usually because a stitch has come off or a scab has come off 7 to 14 days. It could be quite significant. I've had to return patients to theatre who've lost 2, 3 liters of blood from a hemorrhoidectomy. Um, Urinary retention, 5 to 20%, particularly in older men, um, but more associated if they've had a spinal anesthetic, if the pain wasn't controlled and they had a lot of intravenous fluids during the operation. Um, Infection is rare, surprisingly. It's not common at all, but deep pelvic sepsis is very even rarer. It's sort of 1 in 500, but could be life-threatening if not recognized early. Fecal impaction, not uncommon because of pain and the liberal use of opiates. Um, Late complications, anal stenosis, delayed wound healing, minor fecal leakage. And I say minor because in my from my experience, major incontinence, where a patient becomes incontinent, generally means the operation went wrong. It was either done by the wrong person or they were having a bad day and they divided the anal sphincters. A colorectal surgeon should never divide the anal sphincters because you look for them. That's the first step of the procedure. You protect them before you ligate the hemorrhoid. Recurrence, not listed. It's not really a complication, but it's just something that could happen. And, we tell patients up to 1 in 20 chance of it coming back. It probably is a bit higher. But because it's one of the things that patients will come back with, it goes on a consent form. Persistent pain, so some patients continue to have pain, chronic pain afterwards. And in that situation, reassess. There could be a fissure, they could have an underlying infection, there could be a fistula, so your diagnosis might have been wrong. So, for those who know their flowers and are keen gardeners, the saying certainly here in the UK that if it looks like a dahlia, operation's a failure. If it looks like clover, problem's over. So this is how a post-hemorrhoidectomy anus should look like. If there is no skin, if the wound is circumferential, then you're in deep trouble because it's going to stenose. And this is what anal stenosis looks like, a complete disaster. So if you excise all the hemorrhoids circumferentially, it will heal like this, and they won't be able to poop. And you can repair it with a VY plasty and all sorts of things, but it's never going to be like an 18-year-old anus again. It's going to be a lifelong struggle. So really important that only people experienced in doing hemorrhoidectomy. I'm more reluctant to let a trainee, a registrar, a resident do a hemorrhoidectomy without me looking and breathing over their shoulders than I would allow them to do a right hemicolectomy laparoscopically because they're less likely to cause life-changing things that I couldn't fix. So counseling beforehand, they need to know what's to be expected. One of my patients, described the pain afterwards as like passing a hedgehog the wrong way around with the spikes out, just that the hedgehog wouldn't come out. And that's how he felt for a week. So we need to manage expectations. Hemorrhoidectomy is the most painful operation you could perform, which is why we should try the other measures first. Don't do it on everybody. Only do it on a patient that will appreciate it because their symptoms are so bad that that's what they needed. Maintain soft stools, fiber, laxatives. Bleeding may occur for up to 2 weeks and seek urgent review if they don't feel unwell, fever, urinary retention, severe pain, or heavy bleeding. So the first is just going to bring up, just to explain that these are not, they're not always straightforward. And I'm conscious that I'm not talking to pure colorectal surgeons here, so I'm not going to go into too much detail so I don't bore you. But if you have a female who eh, is multiparous, for example, might be going through the menopause or might have gone through the menopause, and they present with protrusion, they tell you they've got this heaviness down below. You have a look and they have grade 3 hemorrhoids, but they're not very exciting. They tell you they can't really poop properly. They go several times, they have to stick their fingers either in the vagina or in the anus to help it out. Then start to think about alternatives like internal intussusception. Have they got an occult prolapse, an internal prolapse of the rectum? And these are the sorts of cases that we should think about referring to a specialist. You would do no harm by banding their hemorrhoids, but it is extremely unlikely that you would help them or make them better. They're likely to lose trust because you would do something that's not going to help them. Because in many women, hemorrhoids are not very common in women. They're much commoner in men. And in women, they're usually secondary to other things like childbirth, as I say, like failure of the pelvic floor for other reasons. So ask more questions and investigate, do a proctoscopy because you can see an intussusception doing a proctoscopy. If you ask the patient to bear down with a proctoscope inside the anus, you would actually be able to see the rectum folding into itself. So here we're going to jump to fistula. What is an anal fistula or fistula in anal? So this is an abnormal connection. So basically, I like this diagram because it explains exactly what happens. It starts off as an abscess forming in one of the glands of the anus, and it goes into the ischiorectal fat. or the ischioanal fat. And it's got two options. It could either burst back into the anus where it came from, or it could make a tract here. Or it points on the skin, and some bright spark, us surgeons go and lance it, and we make a cut there. And by definition, we've converted it into a fistula because this is where it came from, and you've now made a cut here. But we discourage people trying to look for the fistula in the acute phase. So if a patient presents with an abscess, just drain the abscess and leave it alone. Bring the patient back to clinic and check if it is completely healed or if there's a fistulous tract. If there's a fistulous tract later on, first thing is to just put a Seton sling in it, which is a rubber sling, or you could use a suture, a braided suture, or a monofilament suture, and tie it inside the canal. And this is just to keep it clean and to stop the abscess forming, and then come back another time to do a definitive procedure. The key principles of fistula surgery is to avoid incontinence, to be able to measure, and these days most patients would have an MRI before we operate to estimate how much anal sphincter is involved so that we can decide which operation to do. And the time we've got today would not allow us to go into the details, but if anybody's got specific questions, I'll be happy to answer them. So anal fissures, they could be acute or chronic. And if they're acute, the lifestyle measures are the first things to do. If they're chronic, they're likely to go away with the lifestyle measures and you often have to do something else. They're usually posterior. Fissures posterior meaning clock face. So we're talking 6 o'clock, which means the part of the anus that is at the back towards the coccyx. And the 12 o'clock is the part that is anterior towards the perineum, towards the vagina in a female, or towards the scrotum in a male. Anterior fissures I've never seen in a male, but in a female, they often are a consequence of something else going on inside. They're not usually ischemic fissures from straining. They're usually because of intussusception pressure from the inside, from a rectocele bulging down from an intussusception and the hypotonic sphincter. So it's really important when you assess a fissure to see whether it is a low pressure system or high pressure. So most patients with an acute fissure will not allow you to do a digital rectal examination because the anal sphincter is going into spasm. If you find a fissure in a patient with a lax sphincter, then the treatment is completely different. Please do not go and do a lateral sphincterotomy because you will render them incontinent. So evidence-based algorithm, I won't read this out because I'm happy to share the slides, but it starts with inspection, lifestyle modification, topical therapy, injection of Botox, lateral sphincterotomy, and follow-up and reassessment. And secondary fissures, I just wanted to mention, I've already touched on constipation, obstructive defecation. We know that patients with Crohn's disease can have fissures. We know that many sexually transmitted diseases can present with fissure-like appearances or fistula-like appearances. And here the history particularly is important to get, particularly of, uh, their sexual history and, in an open, non-judgmental way, particularly men who have sex with men who have anally receptive intercourse, can have STI presentations that mimic fistula or fissure. And of course, anal cancer or its precursor stages of anal intraepithelial neoplasia, where patients who have the precancerous stage of anal cancer could have things that look like skin tags, but they look hard and whitish, what we call leukoplakia. And so that's important to define. And on examination, irregular outline, multiple fissures, always more suspicious, occurring laterally. They're usually anterior or posterior, or do not improve with treatment, need to be investigated further. And we don't use nicorandil anymore, but when it was in common use, there were typical nicorandil ulcers at the 6 o'clock position, which again was a significant differential then. So again, this is simple, straightforward. Young postpartum patient with severe pain, blood and wiping, no change in bowel habit. So, no need to go and look inside. It's clear that this is something that's happened around the time of childbirth. So give topical treatments like glyceryl trinitrate, ointment, diltiazem, or nifedipine, all working by relaxing smooth muscle. So skin tags, my favorite, not. Um, Key thing is they're there for a reason. So skin tags do not form by themselves. They're leftovers of when the patient had hemorrhoids that were protruding or they had an anal fissure that's healed. So they're usually pointing at something else or there's something else that's caused them. So on their own, if they don't look suspicious, leave them alone, right? It's always, it helps me when patients ask for cosmetic reasons and you sort of think, well, who's looking, right? Leave it alone. There's a reason nature put it down there. It's not for showing off to the public, right? So reassure asymptomatic patients, treat the underlying pathology, excise only if genuinely symptomatic. Some patients have very pedunculated elephant ear type tags that interfere with hygiene. Yeah, by all means. If they look suspicious, think about Crohn's disease, think about malignancy, as we've discussed. And certainly the NHS, we're not allowed to remove skin tags for cosmetic reasons. And the key thing is don't ignore if they're atypical or ulcerated. And again, what's the difference? So external skin, we often have hemorrhoids referred as skin tags as hemorrhoids. So there are internal and external hemorrhoids. They're two completely different things. So you can get skin tags could be leftovers of when the patient had external hemorrhoids. But hemorrhoids always look purple, swollen. They could be painful if they are engorged, if they are thrombosed. But a skin tag is skin. It looks like the rest of the skin. And you could also have anal polyps, fibroepithelial polyps, which could sometimes be pedunculated and hang out. And they could sometimes cause fecal soiling because they interfere with the closing of the anus. So again, differentials, Crohn's disease, condyloma acuminata, which is sometimes a sexually transmitted infection as well related to the human papillomavirus, anal cancer, and think rectal prolapse. Could it be a rectal prolapse rather than hemorrhoids? So guidelines wise, there are lots of guidelines from the ASCRS, the ACPGBI, and they all talk about the same thing with hemorrhoids, fiber first, rubber band ligation, surgery for advanced disease with chronic fissure, topical therapy, inject Botox, lateral internal sphincterotomy, skin tags. All the guidance says leave alone unless symptomatic or look suspicious. So the key highlights, the Cochrane reviews uh, say fiber reduces persistent symptoms and try that before anything else. Rubber band ligation is most effective of the office treatments still. Internal sphincterotomy has a 95% healing rate for anal fissure, but 1 in 10 patients, particularly men, when they get to their seventh decades, that's their 60s, will start to experience some fecal soiling, which might be related to the fact that somebody went and slit their anal sphincter. So if you can persevere with the non-surgical treatments, it is better long-term for the patient. So key take-home messages, we're rounding up now. Uh, Treat conservatively first, exclude malignancy by looking carefully, inspecting, feeling, and putting a camera inside. Individualized intervention. So there shouldn't be, a flat rule. We shouldn't have my favorite operation that everybody gets. The operation should suit the patient, and some patients should be declined. Just come to mind as not in the presentation, but think about patients who are known to have chronic liver disease, their hemorrhoids might be part of their presentation of portal hypertension. So do not, they could be rectal varices. Do not go and band them unless they're causing significant bleeding. And these days we have other ways of treating them by interventional radiology. Do not operate on them because they will not stop bleeding and you will regret it. And if you're not sure, refer to somebody who knows, usually a colorectal surgeon. Certainly in the UK, in other climes, it could be a general surgeon with an interest in proctology. So I've listed some of the references and the guidelines that I've turned to it doesn't change. Proctology is a very old um, field that's been going back to Hippocratic times. The tools have changed, but the principles are the same. Do not make the patient incontinent. And abide by the Hippocratic oath as always. Do not leave your patient worse than you found them. Do no harm. And thank you very much. I'll leave you with the CME slide once more.
Thank you, thank you, thank you. We have some really, really good questions. If you put the slide down and then I'll just start reading the questions to you. We'll take one at a time. So the first question, it's from Tefri Merid. I may not say names just so I don't mispronounce or insult anyone when I pronounce their names. But the first question, in which group of patients um, should you perform rubber band ligation? Is it in all cases?
Yeah, excellent question. So rubber band ligation should be performed for the symptom, not the hemorrhoids. So any patient who's largely bleeding can have rubber band ligation. So even if they have grade 4 hemorrhoids that are protruding, if the patient's not complaining about the protrusion, then by all means start with rubber band ligation because we know it has an 80% efficacy when it comes uh, to reducing symptoms of bleeding. So every patient presents with bleeding, rubber band ligation first. Definitely start with an office procedure. But if the patient is complaining about protrusion, then rubber band ligation is a waste of time because that's not going to deal with the prolapsing hemorrhoid that needs a surgical procedure to fix.
Perfect. Hopefully everyone has got the CME information. We'll stop sharing now.
Oh, sorry. Would you like
No,
me to put
no,
it
no, no,
back
no,
up?
you're good.
All
No,
right.
no, that was perfect. That was perfect. All right, so let's move on to the next question. Good evening, sir. How often can one perform rubber band for a case of hemorrhoids? And how many hemorrhoids can one band at a time? So how
Yeah,
often
good
can you
question.
band? Yeah.
Yeah, good question. So there's a really good talk at the last tripartite meeting by an American surgeon. I've forgotten her name now, but she's the queen of hemorrhoids in the States. You might have come across her, but it's gone. And she insisted that you should only ever do two, never do three, because it's painful and you should give an opportunity to repeat the procedure so don't cause too much scarring. And that was interesting because in the UK we're trained to ban three hemorrhoids all the time.
Mm.
I've not noticed it to be a problem. Um, but the simple answer is you can do it as often as required. As we discussed, there are generally three hemorrhoids at 4, 7, and 11 o'clock. So I've never seen hemorrhoids anywhere else in the clock face. I've never seen somebody with hemorrhoids in a different place. So that is where you should ban them. I haven't gone into details about the procedure, but who should do them? It's an office procedure. It does not have to be a surgeon. It tends to be surgeons who do them by tradition in the UK. I don't know about the practice, Akwi, in the States. Do gastroenterologists ban hemorrhoids?
Yeah, and then I think the key thing is experience.
Yeah,
Trained,
yes,
individuals who've actually been trained to
100%.
perform it. Yeah, but
Yeah,
yes, we have gastroenterologists who actually
yeah,
perform the banding.
yeah.
And there was a follow-up clarification. How often did you say?
How
You- you-
often? As often as there's no limit to the number of times. So the general timeline is about 3 months. So I would never repeat it less than 3 months. So I would ask the patient not to get in touch before 3 months because it's still scarring and fibrosing and
Mhm.
the it could still improve after 3 months, but you could repeat it. But I've found in general by the second treatment, it's very unusual for patients to come back. And if they come back, it means it's not just the hemorrhoids, there's something else going on. They might have a prolapse, which needs to be dealt with in a different way.
Okay. The next question. So, thank you, Dr. Ahmed. Here are my questions. What are the indications for surgery in hemorrhoids? I'll just ask them one at a time. What are the
Yeah.
indications for surgery in hemorrhoids?
So indications are the patient cannot tolerate their symptoms and has not improved with non-surgical treatment. So regardless of the size, and it's an excellent question because we often have get referrals from primary care where the patient has been told your hemorrhoids are very big, they have to be removed. I'm going to refer you to a surgeon. But actually, the patient didn't know they were there. They were carrying them around. So if they're asymptomatic, please leave them alone
Yeah.
because it might be that they're helping to keep that patient continent. So asymptomatic hemorrhoids of whatever size that has no suspicious features, no indication for treatment. But in terms of the different groups, as we discussed, prolapsing hemorrhoids, uh, require surgical treatment. Grade 4 hemorrhoids need an excisional hemorrhoidectomy because that's the only way you're going to get rid of the external component.
Yeah, no, that's really a good point because sometimes you perform a colonoscopy and you find hemorrhoids and you write that in your report and the patient's like, well,
Yeah.
what now? And it's like, well, it's
Yeah,
a cosmetic issue, nothing to worry about. As long as it's not
correct.
bothering you, we don't bother them.
Yeah, yeah,
Um,
100%.
the second question is, how do you grade hemorrhoids clinically?
So on seeing them, yes. So inspection, the first thing is when you have a look, on the anal verge at rest. So before, the really key thing, take time to look at the anus. As I said, you can tell that I'm biased, right? I think it's a very important organ. Give it the time it deserves. Have a look at it. Don't be quick to stick your finger in it because you lose the trust of the patient. So take time to look at it. Ask the patient to cough to see if they have leakage when they cough. Ask them to bear down, open their mouth, breathe through their mouth to relax them. Um, Push down gently and see if the hemorrhoids protrude. If they protrude, then and return spontaneously, they're grade 2. If they protrude but wouldn't go back without being pushed, then they're 3. If they were there before you started, then they're probably grade 4. And if you try to reduce them, they wouldn't go back in, then they're grade 4. But if they weren't there, so the sort of hemorrhoids that we see when we do retroflexion and colonoscopy, that did not come out when the patient strained and are the grade 1s, that's normal. That's just what we are born with. But as you said, Akwi, the patient has, the patient has been told
Mhm.
it goes on a report because you've seen it, so you describe it. But it's important that you clarify to say
Right.
this is a normal finding, right?
Yeah.
Everybody's got three of these. Yeah.
The next question is with regards to pharmacological management, would you recommend Anomex? So I don't know if you know if it's called the same medication, but Anomex and Anusol as most effective, and how long should you prescribe them? Do you call it
So
Anomex in
I
England
know
as
what
well?
anisole is. I
Yeah,
don't know what Anomex is. Is
yeah, I
it
didn't.
similar preparation? Zinc
Actually,
type?
I had to look it up
Zinc
because
oxide?
it's a hydrocortisone acetate. Like I didn't know that it was called Anomex as well.
Yeah. So
Yeah. So it's yeah
steroid creams
with zinc oxide. Yeah.
and steroid.
Yes. Yeah.
So
So it's
yeah.
and lidocaine.
That's really bad news, steroid on the anal skin.
Mhm.
We do a lot of educational talks to discourage our primary care colleagues from prescribing hydrocortisone containing creams because it really thins out the anal skin. It
Mhm.
causes it to excoriate and to break. And the worst thing is it stops anal fissures from healing because steroids, impede healing. So if somebody's got, and they often prescribe them for pain, and painful bums generally have fissures in them. So um, those preparations do not help. There's no evidence at all that they help to heal, to make hemorrhoids better or fissures. Um, they give a transient relief because the zinc oxide is a soothing agent. Lidocaine would give you. So if you're going to use anything at all, I would say to people, use lidocaine with maybe the zinc oxide because it will give you some temporary relief, but it would not help to heal the fissure or improve your hemorrhoids. There is no long-term benefit to using them at all.
Thank you. The next question, I think you've answered this sort of, but I'll just ask it anyhow. So thank you for the presentation. How exactly can external hemorrhoids be differentiated from grade 3 or 4 internal hemorrhoids when inspecting the anus?
Ah, excellent question. This is really, really good one. So grade 4 hemorrhoids are when the internal hemorrhoids get married to the external hemorrhoids, right? So they're inseparable, right? That's why they won't go back because part of them belongs outside. So this is when the internal hemorrhoids have pushed down, but they've also connected to the external hemorrhoids, which do exist. We all have small external hemorrhoids, and they've got the same role. They help to keep the anal verge closed. So, so that's the key thing. Whereas internal hemorrhoids, the grade 3 hemorrhoids can return into the anal canal. So that's the difference, but you have to manually reduce them because there is a degree of mucosal prolapse that brings them down.
Thank you. The next question, how can you differentiate skin tags and hemorrhoids in Black people?
Oh, yeah, really good one. Really good one. So we talked about the nature of them. So skin tags are skin. Hemorrhoids are a collection of blood. So they're squidgy. When you press on them, you can feel that you will be able to partly empty them. You could squeeze them if you hold them between your index finger and your thumb, you'll be able to partly empty a hemorrhoid, whereas you can't empty a skin tag. And the hemorrhoid, even in a dark-skinned person, will have the purpley
Mm,
appearance on it, regardless, because internal hemorrhoids are coming from inside.
yeah.
And we're not pigmented inside us. As I keep saying to people, once you pass the dentate line, we're all pink, right? Everybody's hemorrhoids are purple once they come outside. So it's the external hemorrhoid, some of the grade 4 part of it can be dark skin because it lives outside. But the hemorrhoids that are prolapsing will have the same color generally. So if it looks like the skin, then that part that you're looking at is likely to be a skin tag.
All right. The next question, this was actually asked twice. How do you differentiate rectal varices versus hemorrhoids in colonoscopy? The other question was the same. How do you differentiate between hemorrhoids versus varices secondary to liver disease? So yeah,
Yeah,
rectal varices versus hemorrhoids.
really good one. So I didn't have the presence of mind to put a photo, but obviously Dr. Asombang and the colleagues see it a lot more than we do. But the key difference is that with rectal varices, just like you could have a caput medusae around the umbilicus, you would see very angry veins in the rectum that are feeding the hemorrhoids. Whereas in a non-portal hypertension situation, you would see some veins, but some hemorrhoidal vessels, but they're not impressive. Whereas in varices, you can see tortuous veins that are leading to the varices. It's quite a classic appearance, and in experienced eye, hands, it's very easy to make that distinction. The hemorrhoids themselves, when you look outside, you won't be able to tell when you're looking outside. So this is why it's important, particularly in patients with a history of liver disease, that you inspect inside with either a rigid scope, but ideally a flexible scope, so you can get good pictures.
Thank you. The next question, thank you for your presentation. How do we identify the sphincters, internal and external, during open hemorrhoidectomy? And what is
Yeah,
the superior extent of dissection and ligation?
right. Yeah, really good one. Um, Let me see. Yeah, in the interest of time, I won't go back to I didn't do a step by step considering it was a largely gastroenterology audience. But the key way to identify the sphincters is to use a proctoscope to stretch the anus. So when you stretch the anus, the internal sphincter forms a band, which is easy to feel. So you can feel the lower edge of the band. And when you indent, you can then, when you sort of, if that was the sphincter, I'll try to use my hand if it will work. So if you rolled your hand over the edge of the internal sphincter, your finger, the tip of your finger would drop into a space that is between the internal and external sphincter. But obviously, what you're looking to do is to separate the hemorrhoids from the internal sphincter. So the first step of the procedure is to excise the external component, to make an incision on the skin, and then to undermine that incision with a dissecting scissors or diathermy device, and interposing yourself between the sphincter and the hemorrhoidal pedicle. And the apex of the dissection is the top of the pedicle, so it will naturally narrow down towards the hemorrhoidal artery that is supplying that hemorrhoid, and that is the point at which you ligate it, either with an energy device or by tying a stitch around it. So it was really a standard operation. The most important message to say it is that this operation is one that, like every other operation, but it needs to be taught. You need to learn it from somebody who's an expert at doing it. That's the way to know how to identify them and where to stop. There's no number of YouTube videos that somebody can watch that can teach them how to do it properly. Yeah.
All right, the next question. What's the role of a sitz bath in managing hemorrhoids and or other anorectal conditions?
So sitz bath, it really good. I encourage it, particularly after surgery or when patients have thrombosed hemorrhoids. So uh, there might be some who are not aware of what sitz bath is. So that's using salt water, warm, sitting, put in your bottom inside a bath of warm, salty water. And it acts as a hygroscopic agent. So it takes out some of the swelling. It acts as a disinfectant as well. So really key. So it's standard part of our protocol after hemorrhoidectomy or any anal operations, because there's good evidence that it reduces swelling and possibly reduces inflammation. It does that probably by reducing inflammation, and it's a good pain relief as well. So liberally, anybody who has a painful anus, apart from when you have a fissure, if you have an acute fissure and you do a sitz bath, you would hit the ceiling quite quickly because it will be incredibly painful because you're rubbing salt in a wound, literally. So in a fissure, probably not as useful. But when you have engorged hemorrhoids or thrombosed hemorrhoid, or when you've had an operation, then really good measure to relieve pain.
The next question. What is the role of diversion colostomy in fistula and ano?
Yeah, it does have a role, but it's usually in the context of a watering can perineum, particularly in Crohn's patients that have multiple fistulae opening out around the anus, and uh, it usually helps the inflammation to settle while the patients, so getting rid of the sepsis so they can have biologic therapy, for example, to help heal the fistulae. And sometimes it's just relief for the patient because imagine, sometimes it looks like the whole thing's falling apart. It's all swollen. There's, opening their bowels is sometimes become partly incontinent. So it's sometimes just, symptom relief for the patient. So on a case by case basis, it does have an important role to play.
All right, thank you. The next question. What is the relationship of sexually transmitted diseases and hemorrhoids?
Um, no correlation as far as I can tell. So we discussed potential relation um, to fistula-like conditions or suppuration or proctitis, or anal fissures. But to the best of my knowledge, there is no correlation between hemorrhoids and sexually transmitted infections. It's largely a mechanical problem of pushing too hard or something sitting heavily in the pelvis like a baby or a tumor that is sitting in the pelvis, but it's purely a mechanical thing. As far as I can tell, infections do not cause hemorrhoids.
Thank you. The next, thank you, Mr. Ahmed, for your excellent presentation. What findings of anorectal MRI that guide your management in fistula and ano? What are the findings in MRI that would guide your management?
Yeah, really good question. Again, lots of great questions. I'm loving this. So, The key thing we're looking for, the first question is how much of the anal sphincter is involved. The second question is it a simple tract or is it a complex tract with multiple branches? In terms of location as well, we're looking to see whether it's supralevator. In other words, is it extending into the pelvis above the levator ani, or is it infralevator? And this helps us determine what to do. So basically, if you've got very little of the sphincter involved, less than 30% of the sphincter, particularly in a man, it's very difficult to make a man incontinent because the male sphincter complex is very long. And, men don't have babies, so they generally do not have a damaged sphincter from anything else. So in a man with less than 30% simple involvement and simple tract, you could go and do a fistulotomy, which means you cut the fistula open and let it heal by secondary intention, and that would fix it nearly 100% of the time. If there's more than 30% sphincter, particularly the external sphincter involved, the risk of incontinence starts to increase, and then you might think differently. We're talking simple tracts now, single tract of starting with a seton sling, the rubber sling or the suture that we discussed earlier, or doing procedures like lift, which is ligating the part of the tract that's between the sphincters and closing the other ends in the hope that because you've disrupted the tunnel, that it would heal. But there have been so many trials, there are myriads of um, operations for fistula. Nobody knows which was the right one, and it's individualized treatment from fistulotomy, which is dividing it, to fistulectomy, which is doing like an apple core excision. So like using an apple corer,
Mm.
almost like think about it like that to cut out the fistula and close the tunnel, to doing a lift procedure. People are using laser, they're using infrared um, to try to cook the tract and make it to congeal. People have used glue, fibrin glue to try to cover it, but they're all equivalent. There's no single treatment that seems to be superior to the other, and you've just got to go with the principles, start with the simple ones and avoid incontinence. So the complex tracts where the MRI makes a difference. For example, if it's supraelevator, once you've found the tract, you might have to treat them differently. You might drain the main tract with a seton sling, and then you might have to deploy laser or infrared to treat the branching tracts out of it. And then serial MRIs would help you to determine um, which ones are gone and which ones need to be treated. But even if the fistula remains, if the patient's asymptomatic, and they haven't got Crohn's disease and they haven't got cancer, same principle, leave it alone.
Perfect. Then we have about six more, and then we'll wrap up. With your long experience as a surgeon, do hemorrhoids reoccur after surgery?
Yes. So we quote 1 in 20 risk of recurrence. I think it's higher than that personally. I think this is just the ones that come back to us. Um, but I think it's probably more frequent than 1 in 20, more common than 1 in 20 that they come back. The risk factors um, for hemorrhoids recurring is the failure on our part, to educate the patient on the lifestyle modifications that they need to institute, uh, because they can regrow the hemorrhoids. You can stretch those vascular spaces again of avoiding constipation, um, liberal fluids, ensuring that they do not strain. The toileting habits are the key things. Do not push unless nature's asked you to. So
Mhm.
that I think it is probably closer to 1 in 5. I think they recur much more. Its recurrence is much commoner, with the exception of an excisional hemorrhoidectomy, where the recurrence rate for that should be less than 1 in 20. But with all the other techniques, recurrence could be as high as 1 in 5.
Thank you. So here's another one. Thank you for an excellent presentation. We routinely use serial band ligation to manage esophageal varices. Do you think a similar serial approach could also be applied to rectal hemorrhoids to achieve complete resolution?
Yes, I agree 100%. And there are surgeons who would not do any other treatment apart from rubber band. because they believe that, it has a high success rate. It does not carry any risk of incontinence, very negligible risk of infection, and can be repeated. Doesn't need a general anesthetic, doesn't need a theatre. Yeah. So I agree with that. As I've become more experienced, I've become a lot more conservative with hemorrhoids, and I spend a lot of time discouraging patients from having surgery for hemorrhoids.
Yeah, and I think the only thing I'd add to that goes to his point about the experience and training. I think just to, maybe add to it, just because you can perform upper endoscopy and bandesophageal
Absolutely.
varices does not mean you can quickly pop the scope down below and do the
Yeah.
same for the rectum without having some sort of, training and
Yeah.
understanding, because it's not simply scope in. You see what you
Yeah.
think is something to be, banded, and you just band. So I think
Yeah.
that's a critical
It is
point
a
to
really
understand.
important point.
Yeah,
Similar technique, but different organ
right.
and
That's right.
different complications. Yeah.
So the next one, thank you for the wonderful presentation, Dr. Ahmed. I wanted to ask if hemorrhoids are a contraindication to right sigmoidoscopy.
Did they mean rigid, perhaps?
Yes, rigid sigmoidoscopy,
All
not
right.
right.
Okay. No, they're not.
Yeah.
No, they're not. And I do routinely. We've got a digital proctoscope in our clinic, so we routinely examine patients in clinic who've come with hemorrhoids because then we could reduce the huge burden on our endoscopy unit, sending patients just to have a scope because you want to check everything's fine before you operate on them. And when all you need to do is to look in the rectum, and we've actually set up a one-stop clinic where patients get a suppository when they arrive so they can empty their rectum, and then we do a scope in clinic, so it's one stop, and we've checked they haven't got rectal cancer, the mucosa looks normal, and we could go ahead and ban their hemorrhoids in that clinic. Yeah, so it's not a contraindication at all.
All right. Next, good evening, sir. Is histology necessary in cases of hemorrhoid and fistula in anal?
Yeah, so it's a very live debate. I was interested in who's asked this question, what their background is. I don't know whether they're willing to share their views as well, if they're in the same field. So fistula in anal always, because um, we looking to check that there's no underlying condition, like Crohn's, for example. So always with a fistula, 100% send it off all the time. Hemorrhoids, I've stopped sending. But some some colorectal surgeons feel that we're missing the opportunity of um, opportunistic diagnosis of precancerous conditions like anal intraepithelial neoplasia. My counter argument is I've had a thorough look at it. I looked at it and I felt it, and it looked normal to me. So it'd be very surprising if a pathologist suddenly found pre-malignant changes. But the standard practice for most, I think the majority of colorectal surgeons send hemorrhoids off when they remove them. Um, I've never been convinced as to why we do it as historical practice. As far as I'm concerned, if you look at it, if it looks fine, then don't send it. But, we live in a very litigious world and there's a lot of defensive practice. So I can understand why people do it.
The next is more of a comment. Thank you. This was very helpful. The next question, how frequent is the sitz bath recommended in hemorrhoids?
So there's no maximum. I generally ask patients to do it twice a day, once after they've opened their bowels, and then again before they go to bed, because it's pain relief, and for some reason, they tend to be mostly painful at night. But I think it's because during the day you're distracted and you're doing other stuff, then you lay in bed, and then it suddenly comes back. So I generally say twice a day, but I say do it if you want to do it more than twice a day. There isn't a maximum.
And is that a lifelong therapy? That's just a follow up.
No,
When do they stop?
I think it should only be used when they're acutely painful.
Okay.
There's no evidence that it helps to shrink asymptomatic hemorrhoids at all. It doesn't do anything to them long term. It's just pain relief for when they're either thrombosed or you've done surgery on them. or they've become acutely engorged because you've been constipated and you pushed too hard. But no, it's not, it shouldn't, I do not think it should. I'm careful not to make my own guidelines here on the talk, but my feeling, my personal opinion is that it should not be recommended as a lifelong treatment. It should be an intermittent thing that is done when you have a painful bottom.
All right. The next question, what is the role of the ceton in management of high fistula, and what's your experience with respect to its outcome?
Yeah, so I mean, people would know there are two general types of setons. There's something called a cut-in seton, which I'm not a huge fan of, but there are many centers, particularly in India, that have published very good figures of where they they sequentially tighten the setons, and by doing so, the seton cuts itself out through the anal sphincters, but it allows the sphincters to heal behind them so that they are um, so that they heal without leaving a defect in the sphincter, but it's very painful. So I'm not a huge fan of it. In the high fistula, the role is to drain the sepsis, avoiding incontinence, avoiding uh, surgery that will damage the anal sphincters, and then coming back to do another stage where you could either do ligation of intersphincteric fistula tract, try laser, try infrared, try all the other things that you can, as long as you're avoiding damage in the sphincter, you're still winning. So when patients ask me how many of these procedures, what does success look like? I said, as long as you're not leaking, we're still winning, right? We can try as it can take three, four, five, six, seven treatments. As long as you haven't made them incontinent, you're still on on the right path.
Wonderful. We'll take these two last questions. Great presentation. What is the best approach of bleeding hemorrhoids in patients with portal hypertension?
Yeah, so my preference, if you have interventional radiologists in your center, is to coil them. It's very effective treatment and reduces you reduces the blood flow to them, and it allows them to shrink. I think the least favorite always is the least favorite is mine is excision. But certainly ligation, because it's a single stitch. Um, Hemorrhoidal artery ligation again is satisfactory. Banding again is good, but you've got to watch how for potentially torrential bleeding when the bands come off, because you can get a lot of bleeding, and which is difficult to stop because it's venous. It's sort of backflow from an engorged portal system. So I would go, if you've got interventional radiology, go for that first, but don't cut them out because they're actually serving a role. They're helping to control the portal hypertension. Is the reason the body made them. So what you're trying to do is to reduce the blood flow, but you don't want to get rid of them completely.
The next question. Good evening, sir. Please, what are the theories that explain the etiopathogenesis of hemorrhoids? I think you talked
Yeah,
about it.
yeah. So I think yeah, we did mention it earlier, but we'll go through it briefly. So basically, it's a mechanical thing. So these anal cushions are meant to have a small amount of blood in them that allows them to come together in the middle and close the 15% defect that is left in the anus that the anal sphincters have enclosed. Now, if you push too hard because of gravity and pressure of the venous system, you push more blood into them. So it's like a honeycomb. There are partitions within the hemorrhoids. If you put too much pressure, you rupture those partitions, and that's where you could get thrombosis. And then the blood stops returning back into the system. And with each repeat of that episode, you get more and more. Of course, the other the other way it can happen is, as we discussed, with pregnancy, for example, or with big pelvic tumors, is compressing the outflow, the pelvic veins. So the hemorrhoids the hemorrhoidal veins can't return blood into the system, and then they get bigger. So it's purely a mechanical problem that is caused by uh, uncoordinated defecation, usually.
All right, and we'll close off with this last question. This is it's more of a clinical. When should a patient consider coming back to the hospital after a hemorrhoidectomy? I
And
think they're
so,
asking
so,
more like emergency. What is considered an emergency? When should they be
yeah,
worried, et cetera? Yeah.
yeah, 100%. So we say spotting, blood is expected for about 2 weeks. Blood on the paper when you wipe after hemorrhoidectomy, a few drops of blood, but bleeding that is continuous and profuse. So if people are soaking their underwear or soaking their bedding, they need to come back to the hospital. That is not normal. So any bleeding that is frightening to the patient is what I tell them. If it is out of the ordinary, because they can't measure it. People say cupful, spoonful. I mean, you don't poop into a spoon to use how you get to know. So I just say to them, if it's frightening, you need to come back. If you feel unwell, if you've got a fever, if there's pain, unexpected pain, pain should be getting better each day. If it's getting worse, you need to come back. But bleeding can be a life-threatening emergency. If you're worried, you must seek urgent medical attention.
Yeah, and I think just on that note, because part of this obviously is educating the healthcare professionals. I think it's just also understanding whatever your system is. There's some systems in the West where yes, you can easily call the doctor on call. You can
Yeah,
more easily maybe pop in, but if you're not in a setting where you can call someone and ask
yeah,
questions, then it's better to just show up
correct.
than not. And sometimes it's like if
Absolutely.
you have questions, it's better to show up at the hospital than to stay home. I'd rather you came into the hospital for care than to stay home for things to go bad. Because sometimes I know people might be afraid, oh, I'm going to get yelled at, et cetera. Just come on in, get sorted, and then you can be taken care of and sent home. And I think just the wrap up is just, I think we would both agree that, not all bleeding is hemorrhoidal.
Yeah,
So just because you've got bleeding from your bottom, et cetera, do not immediately assume like, oh, this is just hemorrhoids acting up or anything of that sort. Definitely seek care because there's, quote unquote, worse things such as colorectal cancer that, you would need to have evaluated. And it is true too
yeah,
that hemorrhoidal bleeding can lead to, anemia if you lose significant amount of blood, but always think of, worse things such as colorectal cancer. At the same time, bleeding from your bottom doesn't mean you've got cancer. But those are just things that,
absolutely.
we really, I think some of the key take home messages. So this was great. There were like 20 questions there. I just
Yeah,
want to say thank you so much. You really gave us a lot of your time. Really appreciate that. Your time, dedication to education, your time and dedication just to answering all those questions. To everyone who's listening, this session obviously was recorded. It's being live streamed. If technology allows, we will upload this to YouTube so you can go back in and listen again. And you can also go ahead and get your CMEs, and the CMEs are free for some of you who might need that CME. And on that note, I would say good morning, good afternoon, good evening. Thank you so much, Mukhtar. And I will
thank you all. Thanks
see
for
you
having me.
soon. All right, you take good care
Yes.
now. All right,
Thank you. Bye bye.
ciao.